Welcome and thank you so much for joining us for today's Real Talk. I'm here with Dr. Jessica Dykstra, and we're going to take the next portion of today to have a little bit of more of a conversational exchange here and talk about a little more and just kind of get real. So thank you again for joining us, and here's your first question.
All right.
So because the point of these Real Talk seminars is really to inspire and motivate the current and future generations, I wanted to ask you, what inspired you to start working with individuals with autism?
Okay. So I think it actually started when I was in middle school, and I had a couple of students with autism that were in my class, that were included in my class, and I think that's probably when I first kind of started to get interested in that. And then when I went to college, I actually had a cousin who told me to take a course in communicative disorders, and she got me into the field. And then once I started going out into schools and doing volunteer hours, which I needed to do, I got to work with more and more kids with autism, and I really loved it. And then thinking about, I guess, just moving forward and knowing that I eventually wanted to pursue research with kids with autism, that was a lot to do with the professors I had, who just kind of encouraged me in that area and said, you know, once you practice a few years, you should think about coming back and doing a research career. So.
Well, and what keeps you motivated in doing your research with people with autism?
So one of the things that I did was I had this picture frame of a bunch of the kids that I used to work with at my school, and it's literally like, if my computer screen's here, the picture frame's right here. And so if I'm having a bad day, or I'm totally overwhelmed, I remind myself to look at the picture frame and think about those kids, because I do this because I want to help. I want to help individuals with autism. I want to help their families, and I think that's one of the things that really keeps me going. And then, I mean, research is actually a really fun career, and you get to keep learning. So sometimes it's easy to stay self-motivated too. So
yeah, and I think part of it for myself and the students that I'm in class with is, with the rising prevalence, more and more of us know somebody with autism or somebody who knows somebody. And so I think that's that keeps us all motivated and learning about it when you make those personal connections.
Yeah, I think everyone's going to have a personal story soon, you know, that they're going to be touched by it in some way. And that wasn't the case when I was getting into it, but I think it definitely is now. And I was a swim coach and lifeguard, and we had a lot of kids with autism at our pool. So I did actually work with some kids with autism when I was in undergrad through that. So it was fun. Yeah.
So my next question for you, knowing that one of the primary criteria for a diagnosis of autism is that there are deficits in social communication, which really sounds like that should be where speech pathologists get our hands dirty. What do you view as the role of a speech pathologist in diagnosing, kind of from that perspective?
Yeah, so one huge chunk of autism is the social characteristics, like you said, and I think we're in a really good position to contribute to that. And we have a lot of background on what typical development looks like and what some of these characteristics might look like for kids with autism. And so I do think I had the opportunity as a graduate clinician to serve on some multidisciplinary assessment teams, and I think that is a really rich experience to have occupational therapists and speech language pathologists and psychologists kind of all come together on that. I think we have a lot to bring to the table as it relates to autism, and so it's important that that we're playing some type of role on those teams, and whether that's in a school or in a clinic or whatever the case may be, and even considering advocating to be a part of that team if there's not a speech language pathologist that's already on the team that's making those diagnoses wherever you are.
And what would you say about the level of experience that, for example, when I get out and I'm practicing, how much experience should I have before I really try to dive in and become a key player on a diagnostic team?
So I do think actually in your graduate work you're going to get a lot of experience, and it depends, I guess, what some of your placements are, but you might get a lot of experience with assessments and seeing kids with a variety of disorders. I guess it kind of depends on your setting, and you want to feel things out, but you are gaining valuable experience each year. And I don't think that you need to have a ton of experience, because a lot of the education that you're getting is kind of setting you up to play a role. Now, if you're in a situation where you're trying to be the first SLP on a team in a location, that's going to be a little bit harder. But if there's already an SLP in place, I would just ask to see, hey, can I work with you on this team, or can I come observe and see what you do and what you look for with kids with autism, especially if you haven't had a placement that kind of facilitates that as a grad student. Just see if you can get some experiences with SLPs who are already doing that.
Right. Yeah. And that being said, once we're part of the team, I was curious if you could give us a little bit of a tip about, some lines not to cross, because it's within our scope when we have the experience to diagnose autism, but, there are likely some reasons that we haven't been doing it on our own historically. So what would be some good guidelines about how to navigate that?
So I haven't had as much experience with diagnosis, but I would say I think psychologists and psychiatrists tend to play a really key role, and I think it's really important to be partnering with them and making sure they learn a lot about kind of the diagnostic and statistical manual and that kind of stuff, diagnosis from that side. And I also think you probably just want to kind of feel out the dynamics of whatever team that you're on, and seeing how you work together to give that input and make sure that your voice is heard. So I don't know that there's kind of a straight answer for that. I do know when I was a graduate clinician and I did some assessments that we were really careful to not, even though it's within our scope to give the diagnosis, we did a lot of stuff up front, like there's a lot of symptoms that are consistent with a diagnosis of autism, and just being careful with how you word it when you're working with families, and thinking about how you kind of broach the subject individually with them. And if it was just you, I'd definitely want to pull in someone from other fields, like a psychiatrist or psychologist who is familiar with making diagnoses like that too. Does that answer your question?
Yeah, that's really helpful. I think it's a combination of using our expertise and also using our tact, and really being a team player. And just because it's within our scope, it doesn't mean we need to run out and just be, rubber stamping people.
Yeah, I will say that it is, it's highly likely as an SLP that you are going to be the first professional that gets called in for these kids. So you're often kind of going to be the first line. And so you do want to make sure as an SLP, regardless of if you want to work on a diagnostic team or not, that you are aware of some of those like red flags, early indicators, and that you have thought about how you can communicate that to family members and have places that you can refer them to, because lots of times you might be the first person who noticed those signs. They might get called in for, not speaking by the time they're a certain age or something like that, and there might be other signs that haven't been picked up on yet. So it is definitely important, regardless of if you're on a diagnostic team, to be aware of those signs and know where to point parents and how to kindly advocate for them to seek out additional support if it's needed.
Right. Yeah, sounds good. So I wanted to kind of move on to talking about the implementation of research, and you gave us some good directions with what you've done and what some others have done in the past, and talked a little bit about what we can look forward to in the future. But especially when you mentioned a parent that wanted to kind of use that facilitated communication, I know there are some dangers to looking at something that's new and popular but may not necessarily have the evidence base. So maybe if you could give us a few tips about, as a clinician who's out in the world, how do I balance this is new and hip and could be really helpful, but maybe there's not the evidence? How do you kind of navigate that?
Yeah, that's a tough question, and it's hard because the landscape can be changing so rapidly. But I think as a clinician, I think clinicians have to be researchers, their own kind of mini researchers, and really think critically about things. And so you definitely want to use your own knowledge base and then the resources that you have access to kind of explore and see like what really is being done, or are there research teams that are out there doing something with this and they just haven't gotten to the stage where they're able to kind of publish those results yet, or is it just kind of a brand new hot topic that there's nothing actually there? And I think, so for kind of smaller things that might be strategies that you can try, you could try doing that and take data in a way that would allow you to kind of see, is this effective for this child? For kind of these bigger programs that would mean like wholesale change for what you're doing, I would probably tend to hold off until there was a little more research behind it, because you don't want to totally shift directions. I know one thing in my clinical experience when I was working in the schools that I struggled with is making sure that I stuck to trying things even if they weren't working right away, because sometimes for kids with autism it takes a little longer for them to kind of pick up on the routine of whatever you're doing with them. So I think there are times when you want to kind of stick with it and see what the data is showing you. Are they making gains in some of the skill areas you're working on? But I do think that you also want to proceed with caution, especially for things that are, some of those, it seems too good to be true things. When you see those just kind of miraculous stories, I do think we want to be cautious in how we approach those kinds of interventions.
What would you say would be a good time frame? So if I'm implementing something new and taking some data, how long is a good amount of time to graph and see, is this working? Or
so I think that is really tricky. The time I was thinking about it is I was working with some kids who were nonverbal, and I was trying to figure out what type of communication system might work. So should I do, and this isn't necessarily a new intervention, but it's new to that kid, should I try sign language right now? Should I try to use this communication board? We had an assistive kind of AAC expert that had developed a very simple communication board, and I wanted so badly for it to work, for him to be using it productively, that I'm like, okay, and I kept kind of switching directions, and I think it never really gave him a chance to catch on to what I was teaching him. So that was a more complex skill to teach, and I wish I would have stuck it out for at least a few weeks or maybe a few months and been consistent with it, rather than saying like, oh, I don't know if he's getting it, I better try something else. This was a kid who had really significant needs, and he actually had Down syndrome and autism, so there were a lot of complicating factors, but there were other kids like that too, where I wish I would have been more consistent in sticking it out for kind of a few weeks. But I think that varies a lot from intervention to intervention for how long you want to try things out. So,
I think that talking about looking at what's new, I think what you've said has given a really strong support for the idea of understanding the theoretical basis behind something new that you're trying. To make sure, like you had said before with the story about the student who wasn't necessarily a great candidate for the facilitated communication because he didn't have those literacy skills.
Right. Yeah.
So making sure that we understand what the new treatment is based on, at least from a theoretical standpoint, if we don't have all the data to help make sure we're trying to go in the right direction.
And you might be able to pick out strategies that are being used within interventions and see if that kind of lines up with what you... So some of the new interventions are kind of a new way of framing it or selling it, but it might be some of the similar strategies that we talked about that we know work with kids with autism. And so just, I think having a good understanding of the theory behind it, the strategies, the approach that they're using, and making sure that's a good fit. So.
New name doesn't necessarily mean new intervention.
Yeah, I think so sometimes. I mean, a lot of the stuff, there's different ways of kind of packaging things, but there's a lot of commonalities in some of the things that we do with kids with autism. So.
I think that gives us a good direction to go in. So I also wanted to talk about another strategy that you mentioned, which was the peer modeling. And it got me thinking about the idea of role models who also have autism. And I mentioned to you for a minute the story of Daniel Tammet, who has very high-functioning autism and also has savant syndrome. But I'm curious whether you've given any thought or seen any research about what it does for either a student with autism or a family of someone who has autism, and what it might look like to have some positive role models to look to.
Yeah, absolutely. I think kind of in any area of life, when we look for role models, we look for someone who has kind of some similarities to us, right? So I think there's a lot of wisdom in thinking that, these kids need role models of teens and adults who have been successful. There's another author named John Elder Robison. I'm not sure if you've heard of him, but he is in the U.S. and he actually was on our advisory board. And he actually mentioned that he thinks that's really important, and maybe establishing like mentoring relationships, because who better to know what's going to be hard for you when you're out working in this office job than someone who has some of the same challenges and some of the same strengths that you have. And so I think there is definitely value to that. And I think there are, Temple Grandin, we certainly see a lot of. She's kind of the main one, but like you said, Daniel Tammet. But there's also got to be a lot of local success stories of people that are doing well. And what you said about the families, I think families are in desperate need of hope lots of times, and that's what they're hanging on to, and there is hope for them, but there are times when they're not going to see that for themselves or their children. So I think having seen how this has worked for other people, having role models and older individuals with autism, and also maybe their families and how their families supported them and reaching their goals would be a great idea. I don't think there's been a lot of research done on that at all, and I'm not sure how much is happening through some of those, like the social networking that I talked about, how much people are encouraging one another. I think in the kind of Asperger's or Aspie community, there's probably a lot of that going on informally, just from what I've heard about that community, but I don't know that it happens in a systematic way anywhere that I'm aware of. So I think it's a good idea.
Yeah. Well, what you said about, families really needing hope, that tells the clinician a lot about, we need to be realistic, and we need to, make sure that we're not creating false hope, but really have the speech pathologist be a person who's advocating for the family and making sure that they're not, they're not losing hope and they're not losing sight of the strengths of the student.
Yeah. One of the most valuable things about going to that conference that I went to, I know I keep bringing this up, on employment for adults with autism, is there were these stories of families who just did amazing things. There was a kid who used a communication device, and he did the whole presentation on his own, and it was just incredible. It was like just this litany, this huge list of things that people told him, like, your IQ is this, you're not going to be this. And then it was all the list of things that he is and that he is to his family. And so I do think that it's really important to keep in mind the strengths and being an encouragement and an advocate, like you said. So
that's awesome. Okay, so moving on more, talking about what the role of the SLP is, I think my perception from where I stand is that we are trained to become a jack of all trades. And so your research is focused, and that's something that we see in people who do research. They sometimes branch off in strange directions. But what are your thoughts about a speech pathologist in serving a population of students with autism when we are expected to specialize in so many things versus, kind of choosing as a clinician to specialize in autism? Where do you see the pros and cons of those two different sides?
So depending on kind of what setting you're going into, you're going to end up seeing different population of individuals, and I think people can end up kind of self-selecting into specialization. I think I did that a little bit in my clinical work because I went to a school that served only kids with disabilities, and so I got the opportunity to specialize in something that I was really interested in, and that fit for me. And I got to learn more about occupational therapy and music therapy and art therapy and behavior protocols and, you know, a bunch of things that I wouldn't have gotten to see as much of in kind of a general school setting. And so for me, that specialization that I kind of did, I guess, through my clinical fellowship year in some ways and then moved into a job was helpful, and I think I was better able to serve those kids that I was seeing because of the other knowledge I was gaining in that setting. But at the same time, we need SLPs who can be in a kind of a general education school and see kids broadly, or be in a hospital clinic and see a variety of patients. So I don't think that, I think it would be hard to move towards total specialization because of kind of the settings that we're working in. But each setting has its own unique kind of characteristics. Another good example is people who are doing birth through 3, working in the homes with parents where you're kind of actually working with the parents on coaching a lot more than maybe you might be working with the child on something. Like that is a real, I think that's a specialty. Being able to work with adults is a lot different to me than being able, and coach adults how to work with kids than being able to work with kids. So I think there are areas, and clearly in, you know, in medical settings, there's some really complex things that SLPs are doing. So I do see the value of specialization. I don't know how much of that should happen within a program versus kind of the mentoring that you get. In my CF, because of the school I was in, there were 8 other SLPs. So I had a great CF experience because I had an SLP across the hall from me and 5 down the hall, and it was really easy to get feedback on what I was doing. And that's not the case if you're in kind of like a rural hospital or something like that. So
yeah. And I think the idea of having programs that prepare us for a wide array allows us to see some of the connections and the strategies that can be used across populations that might be helpful, especially when you're looking at a spectrum.
Yeah.
No child is the same, so you know it stands to reason that similar presentations might have similar strategies that you could use to get at those.
Yeah, I think and I think there could be some really good ideas in other areas that you get exposed to. So I do think it's good to kind of get that full picture, but it is helpful when you're working with some populations to have more knowledge. Even just behavior management techniques were really helpful for me to know when I was doing my work. So I would have been lost without those.
Right.
I don't know that I would have learned them in some other places. So.
Well, the last question that I have for you is a type of wrap-up for our real talk today. And I was hoping that you could answer briefly, and we'll see if you can hit that 6-word sentence mark. But the question is, what is the message that you would like to send to current and future generations of clinician researchers in the field of autism spectrum disorders?
Okay. So I have been trying to think about this. Let's see if I can get the 6 words. So I think I would say small steps to reach big goals.
Small steps to reach big goals.
I think one of the, can I go on now?
Yeah,
because
please.
Now I'm expanding on my 6 words.
Please do.
I think it's easy to lose sight of both of those. So sometimes you're looking at a skill that a child maybe should have by a certain age, and you see where they are, and you're like, okay, so where do I write the goal to get them there? And I think it's important to find those small, meaningful steps, but keep your eyes on the big picture for that child and that child's family, or that individual's family, and working towards that. So I think being focused, but not kind of losing the forest as you're focusing on the trees, I guess. So, and just being positive and keeping in mind that individuals with autism have a lot of awesome strengths and contribute a lot to our society, and so thinking about the ways that we can support them in just maximizing their experiences in life.
Well, that was wonderful. Small steps to reach big goals. Thank you so much for being with us, Dr. Dykstra. We really appreciated it.
All right,
thank you for being our first real talk.
It was fun.